I'm Dr. Sarah Mitchell, an emergency physician at St. Mary's Hospital, a place where the pulse of life and death beats with relentless intensity. Over the years, I've grown accustomed to the chaos and urgency that define our emergency department, a space charged with the raw energy of human fragility and resilience. St. Mary's is not just any hospital. It's a hub of critical care excellence, equipped with state-of-the-art technology and staffed by a team of dedicated professionals who thrive under pressure. We see everything, from routine injuries to the most complex, life-threatening emergencies. Still, amidst the daily whirlwind of trauma and crises, there are moments that transcend the ordinary, moments that challenge what we believe about life itself. The emergency department at St. Mary's is a crucible of high-stakes and split-second decisions. Here, resuscitations are almost routine, each one a battle against time, a race to restore a heartbeat that has faltered. We train for these scenarios extensively. We drill protocols until they become second nature. Yet no amount of preparation can fully ready you for the unpredictability of human survival. The air is often thick with tension, illuminated by the harsh glow of fluorescent lights and the steady beeping of monitors. It's within this charged environment that I have witnessed countless stories of despair and hope intertwined, but none as extraordinary as the one that would forever alter my perspective. On an otherwise typical shift, as I moved through the department, I was reminded of the relentless nature of emergency medicine. The ebb and flow of patients arriving by ambulance or walking in with complaints that range from minor to catastrophic is a rhythm I know well. Our team works seamlessly, each member attuned to the critical needs of the moment. Nurses, paramedics, respiratory therapists, and physicians all converge with a singular purpose: to save lives. The protocols we follow are well established, and while every case is unique, the outcomes often seem to follow familiar patterns. Yet, the true challenge lies not just in the clinical skills, but in the emotional fortitude required to face the fragility of life head-on. The emergency department at St. Mary's is a place where the line between life and death is razor-thin. During my years here, I've seen patients defy the odds, pulling back from the brink through sheer will and the combined efforts of our team. But I have also witnessed the heartbreak of loss, the moments when, despite every effort, the heartbeat fades and families are left grappling with grief. It is a place where hope and despair coexist in a fragile balance, and where every decision carries immense weight. It was in this crucible of human vulnerability that I encountered a case so extraordinary it challenged everything I thought I knew about the boundaries of resuscitation and recovery. The story begins with the arrival of a patient whose condition was, by all clinical standards, hopeless, a man who was quite literally dead upon arrival. Yet, what unfolded that day would force me to confront the mysteries at the very edge of medical science and human endurance. Before that pivotal moment, I often reflected on the nature of death as it presented itself in the emergency room. Death in our field is not a single event, but a process, a gradual fading of biological functions marked by the faltering of breath, the cessation of the heartbeat, and the loss of neurological activity. We are trained to recognize these signs swiftly and to act decisively. Advanced cardiac life support protocols guide us through the steps to attempt revival, but there are limits, and those limits are well documented in medical literature and practice guidelines. Yet, despite the protocols and the science, there remains an element of unpredictability, a realm where medicine meets the unknown. It is this space that I found myself navigating on that day. Our emergency department, equipped with the latest defibrillators, ventilators, and monitoring systems, is designed to push those limits, to extend the window between life and death as far as possible. And within this high-stakes environment, the team operates with a blend of scientific precision and human compassion, knowing that behind every code blue is a story, a family, a life hanging in the balance. The culture at St. Mary's fosters a relentless pursuit of excellence, but it also embraces the humility that comes with caring for the critically ill. We celebrate the victories when patients pull through, but we also acknowledge the heartache when survival is not possible. This duality is woven into the fabric of our daily work, shaping how we approach each case with respect, urgency, and an unwavering commitment to do all that we can. That day, as I donned my lead apron and prepared for what I assumed would be another routine resuscitation, I was unaware that I was standing on the threshold of an experience that would redefine my understanding of life's resilience. The emergency department buzzed with its usual cadence, the sounds of monitors, voices, and footsteps blending into a familiar symphony of urgency. It was within this setting that Mark's story would begin, a story that would test the limits of medicine and the human spirit in ways I could never have anticipated. I remember the feeling of anticipation mixed with a profound sense of responsibility as the call came over the radio. A middle-aged man had been found unresponsive, pulseless, and not breathing. The paramedics reported cardiac arrest, and the ambulance was racing towards us. In moments like these, every second counts, and the team springs into action, mentally rehearsing the steps to follow even before the patient arrives. As the ambulance pulled up, the resuscitation bay was cleared and prepped. The team assembled, each member ready to perform their role with practiced efficiency. The atmosphere was tense but focused, a familiar setting for me as an emergency physician. I knew that the coming minutes would be a battle against time, a race to restore life where it had seemingly fled. But even amidst the routine preparations and the well-rehearsed protocols, there was an undercurrent of something different that day, a sense that this case would not be like the others. It was the beginning of an extraordinary journey, one that would challenge the very essence of how we understand death and survival. And as I waited for Mark to be wheeled through the doors, I braced myself for what lay ahead, unaware that I was about to witness a medical miracle that would leave an indelible mark on my career and my soul. The ambulance doors burst open, and the paramedics swiftly wheeled in Mark Reynolds, a middle-aged man whose body lay limp and unresponsive on the stretcher. The stark fluorescent lights of the emergency room illuminated his pale, motionless face, and the absence of any spontaneous breath was immediately evident. My heart raced, not with fear, but with the focused intensity that comes from years of experience in the emergency department. This was the moment where training and instinct converge, the moment to act decisively in the face of death. Mark's arrival was a blur of motion. The team moved with practiced precision, positioning the stretcher beneath the ceiling-mounted monitors and attaching leads to capture his heart's electrical activity. The initial assessment was grim. No palpable pulse, no spontaneous breathing, and unresponsive pupils fixed in dilation. The monitor displayed a flat line, a silent testament to the absence of cardiac electrical activity. It was clear Mark was in cardiac arrest. Despite the dire presentation, the emergency department's protocols sprang into action like clockwork. I took charge, barking out orders as the team responded in harmony. An airway was secured immediately. I watched as the respiratory therapist swiftly intubated Mark, inserting an endotracheal tube to control his breathing. Bag mask ventilation was replaced by mechanical ventilation to ensure oxygen delivery. The absence of spontaneous respiratory effort underscored the severity of his condition, but we pressed on, our goal unwavering, to restore his heartbeat and bring him back from the brink. Simultaneously, intravenous access was established, and emergency medications were prepared. Epinephrine, the cornerstone of advanced cardiac life support, was administered at regular intervals, aimed at stimulating cardiac activity. We attached defibrillator paddles, ready to deliver shocks should a shockable rhythm emerge. But with Mark's initial rhythm asystole, a complete absence of electrical activity, our options were limited. The resuscitation algorithms dictated that we continue high-quality cardiopulmonary resuscitation, CPR, alongside medication administration, but the challenge was formidable. The scene around me was a whirlwind of coordinated chaos. Nurses compressed Mark's chest with relentless force, maintaining a steady rhythm to circulate blood to his vital organs. The beeping of monitors and mechanical sounds of ventilation filled the room, punctuated by terse commands and updates. Despite the routine nature of these actions, each resuscitation carries a unique weight, a blend of hope and uncertainty that hangs palpably in the air. As the minutes ticked by, I felt the familiar strain of trying to balance clinical judgment with emotional resilience. The clock is both ally and adversary in these moments. Every second without a pulse diminishes the chances of survival and neurological recovery. Yet, surrender is not an option. The medical team's commitment is absolute, fueled by the knowledge that miracles can and do happen, even in the face of overwhelming odds. Mark's history was scant at this point. A man found unresponsive at home, with no immediate family present. The paramedics relayed that he had been down for an unknown duration, adding a layer of uncertainty to the prognosis. In the emergency department, time is a critical variable, and unknown timelines complicate decision-making. I knew that despite our best efforts, prolonged downtime without circulation increases the risk of irreversible brain damage. Still, the team pressed forward with unyielding determination. We cycled through the resuscitation protocol. 30 compressions, 2 breaths, vigilant monitoring for any return of organized electrical activity. Defibrillation was on standby, ready to be deployed should ventricular fibrillation or pulseless ventricular tachycardia be detected. But Mark's heart stubbornly refused to respond, the flatline persisting like an unyielding void. The emotional intensity in the room was palpable. Though we maintained professional composure, the weight of the situation bore down on us. Each member of the team was acutely aware that this was not just another resuscitation. This was a fight against a silent, merciless adversary. The hope that had initially surged with Mark's arrival began to wane, replaced by the creeping shadow of doubt. Yet, no one faltered. In the emergency department, perseverance is a form of respect for life itself. I found myself reflecting on the delicate balance between clinical guidelines and the human element of care. Protocols provide a roadmap, but the nuances of each case demand intuitive judgment. How long should we continue? When does hope become futility? These questions hover unspoken, yet they guide every action. In Mark's case, the unknown duration of arrest and lack of response to initial interventions suggested a grim prognosis, but the team's resolve remained steadfast. Throughout the resuscitation, I maintained constant communication with the nurses and respiratory therapists, ensuring that each task was executed flawlessly. The synchronization required during CPR is immense. Even brief interruptions can diminish the effectiveness of chest compressions and reduce perfusion to the brain and heart. The physical toll on the team was evident, yet the commitment never wavered. This collective effort, a choreography of urgency and precision, embodies the essence of emergency medicine. As the resuscitation continued, I monitored the cardiac monitor intently, searching for any sign of change. The flatline persisted, a stark reminder of the gravity of Mark's condition. Yet, beneath this bleak surface, a silent hope endured, a hope born not from certainty, but from the relentless human spirit that drives us to fight against the impossible. Mark's body lay motionless, yet within the storm of activity around him, I sensed the profound vulnerability of this man, a life suspended between existence and oblivion. The clinical detachment required in such moments is a shield, but beneath it lies an empathetic undercurrent. Every pulse we seek to restore is a beacon of humanity, a chance to rewrite a story that seemed destined to end prematurely. The minutes stretched, the room charged with a mixture of tension and quiet determination. The team continued the cycle of compressions, breaths, and medication, each action performed with unwavering focus. The weight of the unknown pressed upon us, but the rhythm of resuscitation persisted, a testament to our collective will. In those moments, I was reminded of the fragile boundary we tread as emergency physicians, the thin line that separates life from death, hope from despair. It is a line defined not just by science and protocols, but by the resilience of the human spirit and the commitment of those who stand at the bedside, refusing to let go. As the resuscitation effort unfolded, I remained vigilant, ready to adapt to any change, to seize any fleeting sign of life. The path ahead was uncertain, but the resolve of our team was unshakable. The fight for Mark Reynolds had begun, and in that fight, we embraced the profound responsibility entrusted to us to battle against the silence and bring a heartbeat back to life. The resuscitation effort intensified as we pushed forward with every tool at our disposal. CPR was unrelenting. Compressions delivered with measured force and precise rhythm, ensuring that whatever residual oxygen remained in Mark's lungs could be circulated to his vital organs. The room was alive with the mechanical cadence of compressions, the hiss of the ventilator, and the steady stream of commands echoing off the sterile walls. Each member of the team was locked into their role, their focus a testament to the gravity of the situation. Defibrillation attempts were prepared meticulously. Though Mark's initial rhythm had been asystole, we remained vigilant for any transition to a shockable rhythm like ventricular fibrillation or pulseless ventricular tachycardia, where electrical shocks could restore organized cardiac activity. The paddles were charged multiple times, hand steady in the split seconds before delivering the jolt intended to reset the heart's electrical system. Yet, each shock was met with the unyielding blankness of the monitor, a flat line that refused to break. Emergency medications were administered at regular intervals. Epinephrine, with its vasoconstrictive properties, was injected to increase coronary and cerebral perfusion pressures. Modaron was on hand, though its use was conditional upon rhythm changes that, frustratingly, never materialized. The pharmacologic arsenal was deployed according to advanced cardiac life support protocols, yet Mark's heart remained silent, a defiant void against our efforts. The physical and emotional intensity in the room escalated. Nurses rotated in and out to sustain the exhausting chest compressions, each shift a battle against fatigue. The respiratory therapist adjusted ventilator settings, ensuring optimal oxygen delivery, while the pharmacist prepared subsequent medication doses with exacting care. The team's synergy was palpable, a finely tuned machine operating under the immense pressure of a life hanging by a thread. Despite the clinical precision, the emotional undercurrents were undeniable. We were fighting a losing battle, and yet the instinct to persist compelled us onward. The line between perseverance and futility blurred as the minutes stretched. Each passing second without a pulse tightened the grip of despair, but surrender was not an option. In emergency medicine, the refusal to give up is a creed written into every action. I found myself oscillating between clinical detachment and a deeper, more visceral hope. The protocols guided us, but beneath them lay the raw, human desire to witness the impossible, to see a heartbeat return where none should be. The room held its collective breath, waiting for even the faintest sign of life. And in that waiting, the tension became almost unbearable. Mark's body was cold to the touch, his skin pale and clammy, yet the chest compressions continued with unyielding vigor. I monitored the electrocardiogram intently, searching for any indication of electrical activity, anything that might herald a change. The silence on the monitor was deafening, a stark contrast to the frenetic activity of the resuscitation. The absence of rhythm was a cruel reminder of the fragility of life, and the thin margin by which death can claim its hold. The emotional toll on the team was evident. Eyes were weary, voices measured but edged with urgency. Despite the growing sense of hopelessness, the professionalism never wavered. We were united in purpose, buoyed by the hope that somewhere beneath the clinical bleakness, Mark's heart might respond. The resilience of the medical team mirrored the very resilience we sought to rekindle in our patient. In those moments, time seemed to distort. Minutes stretched into what felt like hours. The relentless cycle of compressions and ventilations, medications and defibrillations became a rhythmic testament to human determination. Yet, the clinical indicators remained stubbornly grim. The prolonged absence of spontaneous circulation cast a long shadow over the room. threatening to erode the resolve that had sustained us. I recall glancing briefly at the monitors displaying Mark's oxygen saturation and end-tidal CO2 levels. These values offer critical clues during resuscitation, reflecting the effectiveness of CPR and potential for return of spontaneous circulation. Unfortunately, these parameters remained suboptimal, reinforcing the severity of his condition. Despite this, the team pressed on, unwilling to concede defeat. Throughout the resuscitation, I kept a mental tally of the medications administered, the minutes elapsed, and the interventions performed. Each detail mattered, each action a potential turning point. The protocols allow for sustained efforts, but also caution us to recognize when to cease attempts to avoid prolonging suffering without benefit. Navigating that delicate balance is one of the most challenging aspects of emergency medicine. The room was thick with an unspoken question: how long to continue when the body resists all efforts? The guidelines provide some structure, but every case is unique, and the decision to persist or halt resuscitation is never taken lightly. It involves clinical judgment, ethical considerations, and, sometimes, an intuitive grasp of the patient's potential for recovery. Despite the clinical indicators and grim prognosis, I sensed a shift in the atmosphere. Not in Mark's condition, but among the team. A shared, quiet determination took hold, a collective willingness to push the boundaries of what seemed possible. The human spirit, both in patient and provider, was engaged in a silent dialogue, one of hope, resilience, and the refusal to yield. The emotional intensity was matched by an almost mechanical precision. Each compression, each breath, each medication dose was delivered with unwavering focus. The room pulsed with the energy of concentrated effort, a microcosm of the battle between life and death. I could feel the weight of every heartbeat we sought to restore, every breath we fought to reignite. As the resuscitation extended beyond typical time frames, I became acutely aware of the physical toll on the team. Fatigue whispered at the edges of concentration, but we rotated roles seamlessly to maintain optimal performance. The shared commitment to Mark's survival transcended exhaustion, underscoring the profound dedication of those who stand at the front lines of emergency care. In this crucible of crisis, I found myself reflecting on the paradox of resuscitation, the simultaneous necessity for relentless action and the sobering acceptance of mortality. Each moment was a dance between science and humanity, protocol and intuition, hope and realism. The complexity of this balance is what defines emergency medicine, and it was laid bare in every breathless second of Mark's resuscitation. Despite the relentless efforts, Mark's heart remained silent, his body unresponsive to every intervention. The prolonged absence of spontaneous circulation was a harsh reality, yet the team's determination did not falter. In that room, amidst the machines and medications, I witnessed the unyielding will of a group united by purpose and the profound gravity of their task. The resuscitation continued, a testament to the intersection of human skill, technology, and the enigmatic will to survive. Each action was a thread woven into the tapestry of care, a narrative of hope clinging to the edges of despair. As I stood at the helm of this effort, I was acutely aware that we were engaged in a profound struggle, one that transcended medicine and touched the very essence of life itself. As the relentless resuscitation efforts stretched beyond what felt like every conceivable limit, a subtle shift began to emerge, one so slight that it could have been dismissed by an untrained eye, yet impossible for me to ignore. After what seemed like an eternity grappling with the silence of Mark's flatline, a faint flicker appeared on the cardiac monitor, a barely perceptible blip amid the unyielding void. It was the kind of sign that could be mistaken for artifact, a stray electrical signal, but something deep within me urged a closer look. The motion of the team faltered momentarily as I signaled for a pause in compressions to scrutinize the monitor. There it was again, a tentative, irregular wave pattern that suggested the heart might be stirring, testing the waters of life after prolonged stillness. It was not a full return of spontaneous circulation, nor a stable rhythm, but it was a pulse of possibility. Those faint ripples were enough to reignite a cautious spark of hope within the room. In that moment, I made the decision to persevere beyond the typical boundaries, to continue with the aggressive resuscitation measures despite the prolonged downtime. It was a choice born of a delicate balance between clinical judgment, experience, and an almost instinctual sense that Mark's body had not yet surrendered entirely. The usual protocols provide guidance, but they cannot capture the nuances of every case, especially when the impossible seems within reach. The team responded with renewed vigor, their fatigue momentarily eclipsed by the glimmer of potential recovery. Compressions resumed with the same precision, medications were readied once more, and the defibrillator remained poised for use. The atmosphere shifted, a cautious optimism threading through the urgency, a collective willingness to push the limits of what we believe possible. I remember the surreal nature of that moment. The emergency room, usually a place of stark clinical focus, seemed to hold its breath alongside us. The beeping of the monitors gained a new cadence, one that hinted at life's stubborn persistence. It was as if Mark's heart was whispering from the depths of silence, a fragile murmur that demanded every ounce of our attention and effort. The team's disbelief was tempered by professionalism. They remained vigilant, aware that hope must be grounded in reality. Yet, beneath their composed exteriors, I sensed a shared sense of awe at the unfolding scene. To witness signs of life after such prolonged arrest is rare, almost miraculous, and it challenges the very definitions we hold about death and revival. We continued with high-quality CPR, ensuring that oxygen delivery and circulation were maintained as best as possible. The ventilator's steady rhythm provided the breaths Mark could no longer take on his own. Medication doses were timed meticulously, with epinephrine administered to support cardiac activity and vasopressors ready to sustain blood pressure. Every element of advanced cardiac life support was deployed with unwavering commitment. Throughout this time, I monitored Mark's vital signs with heightened scrutiny. End-tidal CO2 measurements, which reflect the effectiveness of CPR and are predictive of return of spontaneous circulation, began to show slight improvements. Oxygen saturation levels, though still low, edged upward. These subtle changes, while not definitive, offered further encouragement that our efforts were not in vain. The emotional intensity in the room transformed. What had been a somber struggle against inevitable loss shifted toward a tentative hope, a collective belief that Mark's heart might yet find its rhythm. The team's energy renewed, each member drawing strength from this fragile turning point. I could see it in their eyes, the rekindling of determination and the quiet joy of witnessing a medical possibility unfold before us. I made a conscious effort to communicate clearly and calmly, directing the team with renewed confidence while remaining vigilant for any signs of deterioration. The balance between hope and caution was delicate. We prepared for every outcome, knowing that the path to recovery could be fraught with complications and uncertainty. As we pressed on, the faint cardiac activity gradually became more consistent, though still unstable. It was a slow, halting return, a heartbeat struggling to assert itself after a long silence. The defibrillator remained ready, though the rhythm had not yet reached the threshold for shock. We were navigating uncharted territory, guided by clinical acumen and a deep respect for the resilience of the human body. The presence of Mark's family was not yet known to us, but I sensed their invisible support as we fought to reclaim his life. In moments like these, the connection between patient, family, and medical team is profound, even if physically absent. The hope we nurtured was a beacon not only for Mark, but for those who would soon stand by his side. In the midst of this intense effort, I reflected on the thin line we walk as emergency physicians between life and death. The protocols, though essential, do not capture the full spectrum of human variability and resilience. Cases like Mark's remind us that medicine is as much an art as it is a science, a discipline that requires flexibility, intuition, and above all, hope. The team's unwavering dedication underscored the importance of perseverance. Even when the signs of life are faint and fleeting, the choice to continue can mean the difference between irreversible loss and the possibility of recovery. It is a lesson etched deeply into my experience, one that shapes how I approach every resuscitation. As the minutes unfolded, the subtle signs of life persisted, fueling our resolve. Mark's heart, once silent, was beginning a tentative conversation with survival. The emergency room, a place often marked by finality, became a stage for the extraordinary, a testament to the unpredictable nature of life and the enduring spirit of medicine. In that moment, I understood that our role extends beyond clinical intervention. It encompasses the courage to hope and the willingness to pursue life even when the odds seem insurmountable. Mark's faint heartbeat was a whisper of possibility, a challenge to the boundaries of medical science, and a call to continue the fight with every fiber of our being. Minutes turned to hours as the faint cardiac activity steadily gained strength, a gradual crescendo amid the earlier silence. Then, almost imperceptibly at first, Mark Reynolds began to demonstrate life's tenacious grip. The monitors that had once displayed an unbroken flatline now showed a rhythm, irregular, fragile, but unmistakably his own. Spontaneous circulation was returning. It was a moment that felt both surreal and profoundly hopeful, as if time itself hesitated to grasp the significance unfolding before us. The shift from mechanical compressions to Mark's own pulses was subtle but unmistakable. I watched intently as the arterial line waveform began to rise, signaling that his heart was pumping blood through his body once more. The palpable absence of a pulse had given way to faint but present beats, each one a testament to the resilience that had defied expectation. The room, previously thick with tension, now pulsed with cautious optimism. Breathing, long sustained by mechanical ventilation, gradually showed signs of spontaneous effort. Mark's chest, which had been motionless beneath the ventilator's steady rhythm, began to rise and fall with increasing autonomy. It was a slow, tentative return, but marked a crucial step toward reclaiming life's rhythms. The ventilator settings were adjusted accordingly, allowing him to gradually assume control over his own breathing. The atmosphere in the emergency room shifted palpably. Colleagues exchanged glances, relief tempered by the gravity of what lay ahead. There is a surreal quality to witnessing a patient return from clinical death, a moment when disbelief and hope coexist in fragile balance. The team's exhaustion was momentarily forgotten, replaced by a collective sense of awe and renewed purpose. As Mark's vital signs stabilized, the focus shifted to immediate stabilization. Intravenous fluids were carefully titrated to maintain blood pressure, while vasopressors were adjusted to support cardiac function. Electrolyte levels, acid-base status, and oxygenation were meticulously monitored and corrected as needed. The complexity of this phase underscored the delicate nature of recovery after prolonged arrest. Neurological status was of paramount concern. Pupils, once fixed and dilated, were reassessed frequently, searching for signs of brainstem activity. Though Mark remained unresponsive, subtle reflexes began to emerge, hinting at neurological function that had survived the prolonged period of hypoperfusion. The uncertainty was profound, each small improvement a beacon, each lack of response a cause for cautious concern. The decision was made to transfer Mark promptly to the intensive care unit for close monitoring and continued support. The ICU team, including neurologists, cardiologists, and critical care specialists, prepared to receive a patient whose journey had defied the odds. The handover was thorough, emphasizing the critical nature of Mark's condition and the fragile gains achieved thus far. Transport from the emergency room to the ICU was a quiet procession, the usual urgency replaced by a reverent solemnity. The life that had once hung by a thread now pulsed with tentative vigor, carried forward by the concerted efforts of a multidisciplinary team. The transition marked not an end, but a new chapter in Mark's fight for survival. In the ICU, advanced monitoring and support systems awaited. Continuous electroencephalography, EEG, was initiated to assess brain activity, while targeted temperature management protocols were considered to mitigate neurological injury. The interplay between cardiac recovery and neurological preservation became the central focus of care. Throughout this transition, the presence of Mark's family remained unknown, yet I felt their looming presence, a silent force intertwined with the medical team's efforts. The emotional weight of this moment extended beyond clinical parameters, touching on the profound human connections that underscore every life we strive to save. Reflecting on the surreal atmosphere in the emergency room during Mark's revival, I recall the mix of disbelief and exhilaration that permeated the space. The air seemed charged with a shared recognition that we had witnessed something extraordinary, not just the return of vital signs, but the reclaiming of life itself from the clutches of death. The immediate stabilization efforts were a race against time, a delicate balancing act to support failing organs while minimizing further injury. Each intervention was calibrated with precision, guided by continuous data and the collective expertise of the team. It was a moment where science and art converged, where clinical skill met the unpredictable nature of human biology. Mark's gradual return of spontaneous circulation and breathing was more than a clinical milestone. It was a testament to the resilience embedded in the human body and spirit. The journey from lifelessness to vitality unfolded as a narrative of hope, determination, and the extraordinary power of coordinated medical care. As Mark was settled into the ICU, the enormity of the moment settled over me. We had crossed a threshold seldom passed. A patient brought back from the dead, revived against staggering odds. The path ahead remained uncertain, fraught with challenges and questions, but the initial victory was undeniable. This surreal moment in the emergency room, marked by the return of Mark's heartbeat and breath, left an indelible impression on me and the entire medical team. It was a reminder that within the high-stakes world of emergency medicine, miracles, though rare, are possible. The line between life and death, so often viewed as absolute, revealed itself instead as a fragile continuum shaped by science, perseverance, and the indefinable human will to survive. In the quiet moments following Mark's unexpected revival, the medical team gathered for a candid discussion, both a debrief of the resuscitation and a reflection on the profound implications of his recovery. The rarity of such an outcome cast a contemplative shadow over the room as we grappled with the medical, ethical, and emotional dimensions of what had transpired. Mark's case was no longer just a clinical challenge. It had become a catalyst for deeper inquiry into the fragile boundary between life and death. We began by reviewing the details of the resuscitation, the prolonged duration, the absence of a clear return of spontaneous circulation for an extended period, and the eventual, almost miraculous, signs of cardiac activity emerging after what would normally be considered futile efforts. The physiological mechanisms underlying such a delayed revival were puzzling, prompting questions about factors that might have contributed to Mark's survival. Was it the quality and timing of CPR, the medications administered, or perhaps an individual variability in tissue tolerance to hypoxia? The answers were elusive, yet the case demanded that we consider them carefully. The team's reflections quickly broadened to the broader implications for emergency medicine. Mark's survival challenged established norms about the duration and intensity of resuscitation efforts. Guidelines typically recommend ceasing attempts after a certain time frame without return of spontaneous circulation, balancing the likelihood of meaningful recovery against the risks of prolonged interventions. Yet, Mark's case suggested that these temporal boundaries might not be absolute. It urged us to reconsider how much hope we invest in patients who defy conventional prognostic criteria. As we spoke, the emotional weight of the situation became increasingly apparent. Resuscitation is often a high-stakes, high-pressure endeavor, but it is also deeply human, a moment where science intersects with hope, fear, and the innate will to survive. The uncertainty surrounding Mark's outcome highlighted the delicate balance between medical intervention and the acceptance of mortality. We were reminded that death is not always a clear-cut event, but a process with gray areas that demand both clinical acumen and compassionate judgment. Ethical questions naturally surfaced during our discussion. How long should resuscitation continue when the odds seem overwhelmingly against survival? What criteria should guide decisions about terminating efforts, especially when subtle signs of life persist? The potential for survival must be weighed against the risk of prolonging suffering or subjecting patients to invasive procedures unlikely to yield meaningful recovery. These dilemmas underscore the complexity of emergency medicine, where decisions often must be made swiftly amidst incomplete information. Mark's case also prompted us to reflect on patient quality of life post-resuscitation. Survival alone is not the sole metric of success. Neurological outcomes and functional independence are critically important. The potential for severe brain injury after prolonged cardiac arrest tempers the initial exhilaration of revival. This sobering reality requires transparent communication with families and a multidisciplinary approach to post-resuscitation care, including neurologists, rehabilitation specialists, and palliative care teams. The team's conversations inevitably touched on the psychological toll of such cases on medical providers. The emotional investment required during prolonged resuscitations can be immense, and the uncertainty of outcomes adds to the strain. Mark's journey underscored the need for institutional support systems to help clinicians process the complex feelings that arise, from hope and triumph to grief and doubt. Recognizing the humanity of both patient and provider is essential to maintaining resilience in such a demanding field. Our reflections also emphasize the importance of teamwork and collaboration. The successful resuscitation of Mark was the result of coordinated efforts across multiple disciplines: paramedics, nurses, respiratory therapists, pharmacists, physicians, all working in concert with unwavering dedication. This synergy is vital in navigating the unpredictable course of critical care and highlights the value of continual training and communication. The rarity of Mark's recovery made his case a powerful teaching moment. It challenged us to remain vigilant against complacency and to approach each resuscitation with both rigor and openness to the unexpected. Incorporating lessons from such cases into training and protocols can enhance preparedness and potentially improve outcomes for future patients. We also acknowledge that Mark's case raised broader questions about the limits of medical intervention and the evolving nature of resuscitation science. Advances in technology, pharmacology, and our understanding of human physiology continually reshape these boundaries. Mark's survival was a poignant reminder that medicine is a dynamic field where yesterday's impossibilities can become today's realities. In synthesizing these reflections, I found myself deeply aware of the humility required in emergency medicine. Despite all our knowledge and skills, there remain mysteries that defy explanation and outcomes that surprise even the most seasoned clinicians. Mark's case was a testament to the unpredictable nature of life and the necessity for continual inquiry, adaptability, and compassion. As we concluded our discussions, a sense of solemn gratitude permeated the room. We were reminded that each patient brings not only a medical challenge but a story, a life interwoven with hopes, fears, and relationships. Mark's survival was a beacon of hope, but also a call to approach each case with empathy, respect, and a commitment to the highest standards of care. In the days that followed, these reflections informed our approach to Mark's ongoing care and shaped conversations with his family. We endeavored to balance realism with hope, providing honest assessments while supporting the profound human desire for recovery. Navigating this emotional landscape is one of the most challenging aspects of critical care, requiring sensitivity and clear communication. Ultimately, Mark's case became more than a clinical event. It became a moment of shared humanity, a reminder of the profound responsibilities we bear as physicians. It challenged us to confront the limits of our knowledge, to embrace uncertainty, and to hold space for hope even in the darkest moments. This experience reinforced my belief that emergency medicine is as much about the art of healing as it is about the science. It demands not only technical expertise, but the courage to face life's greatest questions with humility and grace. Mark's journey illuminated these truths, leaving an indelible mark on my practice and my perspective as a physician committed to the delicate balance between life and death. In the weeks following Mark's transfer to the intensive care unit, the focus shifted from immediate survival to the arduous and uncertain path of recovery. The initial miracle of his return to spontaneous circulation gave way to the slow, painstaking process of neurological and physical rehabilitation, a journey marked by incremental progress and relentless dedication from a multidisciplinary team. Watching Mark navigate this fragile phase underscored the complexity of post-cardiac arrest care and the profound resilience of the human spirit. From the outset, it was clear that Mark's neurological status required close and continuous evaluation. After prolonged cardiac arrest, the brain is particularly vulnerable to hypoxic injury, and predicting recovery is fraught with uncertainty. Neurologists became integral to his care, performing frequent assessments to gauge his level of consciousness, reflex responses, and potential for meaningful cognitive improvement. Each day brought subtle changes, slight eye movements, minimal responses to stimuli that hinted at preserved brain function, fueling cautious optimism among the care team. Simultaneously, Mark's cardiovascular system required vigilant monitoring. Cardiologists collaborated closely with critical care specialists to optimize his hemodynamic status, address any underlying cardiac issues, and support his heart's gradual return to stable function. Echocardiograms and other imaging studies were performed regularly to assess myocardial recovery and to tailor medical therapy accordingly. This interplay between cardiac and neurological care highlighted the intricate balance needed to foster recovery after such a catastrophic event. Rehabilitation specialists also became central to Mark's journey. Physical therapists began gentle mobilization efforts as soon as medically feasible, working to prevent muscle wasting and joint stiffness that often accompany prolonged immobilization. Occupational therapists assessed his ability to perform daily activities and develop strategies to enhance independence. Speech therapists were involved early to evaluate and support any swallowing or communication difficulties. This multidisciplinary approach aimed not only to restore physical function, but to rebuild the foundations for a meaningful quality of life. Throughout this process, the involvement of Mark's family proved invaluable. Although initially absent during the emergency, his loved ones soon became a consistent presence at his bedside, providing emotional support that transcended words. Their commitment offered Mark a lifeline of encouragement and connection, essential elements in the recovery of patients emerging from critical illness. The family's resilience mirrored the medical team's dedication, creating a partnership focused on hope and healing. Mark himself demonstrated remarkable determination. Despite the profound challenges posed by his condition, he engaged with therapy sessions, responding to stimuli and gradually regaining strength. His journey was marked by moments of frustration and fatigue, but also by flashes of insight and the innate will to reclaim his life. Witnessing his perseverance was a profound reminder of the capacity for recovery that lies within even the most vulnerable patients. As the weeks unfolded, the care team convened regularly to review Mark's progress and adjust treatment plans. These multidisciplinary meetings were forums for collaboration, where neurologists, cardiologists, intensivists, therapists, nurses, and social workers shared insights and coordinated goals. Such teamwork was essential in addressing the myriad complexities of Mark's condition and in navigating the uncertainties that accompanied his recovery trajectory. The challenges were formidable. The risk of complications, such as infections, secondary brain injury, and cardiac instability, loomed constantly. Vigilance and adaptability were paramount as the team responded to evolving clinical needs. Yet, amidst these challenges, the incremental gains in Mark's neurological and physical function provided powerful motivation to persist. Throughout this period, communication with Mark's family remained a priority. Transparent discussions about prognosis, potential outcomes, and therapeutic options were conducted with empathy and honesty. These conversations acknowledged the uncertainties inherent in post-cardiac arrest recovery, while emphasizing the collective commitment to supporting Mark's best possible outcome. The emotional complexity of these dialogues underscored the human dimensions of critical care medicine. The integration of palliative care principles also became relevant, ensuring that Mark's comfort and dignity remained central to care decisions. This holistic approach addressed not only physical symptoms, but also psychological and spiritual needs, recognizing the profound impact of critical illness on patients and families alike. Mark's gradual neurological improvement was accompanied by signs of cognitive recovery. He began to respond to verbal cues, track movements with his eyes, and exhibit purposeful behaviors. These milestones, though modest, were celebrated as significant steps forward. The team remained cautiously optimistic, aware that recovery after prolonged arrest can be protracted and unpredictable. Physical rehabilitation advanced in parallel. Mark progressed from passive range of motion exercises to assisted sitting and standing. Therapists tailored interventions to his evolving capabilities, fostering strength, coordination, and endurance. These efforts aim to restore autonomy and facilitate eventual reintegration into daily life. The emotional and psychological aspects of recovery were also addressed. Psychologists and social workers became involved to support Mark and his family in coping with the trauma of critical illness and the challenges of rehabilitation. Mental health care was recognized as integral to holistic recovery, helping to mitigate anxiety, depression, and adjustment difficulties. As Mark's condition stabilized, plans for transition from the ICU to a specialized rehabilitation facility were developed. This next phase promised intensive therapy aimed at maximizing functional recovery and preparing for eventual discharge home. The continuum of care exemplified the comprehensive nature of modern medicine, bridging acute intervention with long-term support. Throughout this journey, I was continually struck by the interplay of medical science, human resilience, and compassionate care. Mark's slow but steady progress epitomized the triumph of hope grounded in evidence-based practice. His case reinforced the importance of multidisciplinary collaboration, patient-centered approaches, and the recognition that recovery extends far beyond the moment of revival. In reflecting on Mark's recovery process, I am reminded of the profound privilege it is to witness and participate in such journeys. The road from near death to renewed life is seldom linear or predictable. It is marked by moments of grace, determination, and collective effort. Mark's story continues to inspire me and my colleagues, reinforcing our commitment to supporting patients through the most challenging chapters of their lives. The lessons learned from Mark's rehabilitation resonate deeply within the emergency and critical care communities. They emphasize that survival is but the first step. The path to recovery demands sustained investment, expertise, and empathy. Mark's journey stands as a testament to the enduring power of medicine and the human capacity to overcome adversity when given the chance and support to do so. Mark Reynolds' case quickly became a focal point for medical rounds and conferences within our hospital and beyond, serving as a profound teaching moment for clinicians across disciplines. The rarity of his survival after prolonged cardiac arrest and extended resuscitation efforts sparked intense discussion among physicians, nurses, researchers, and trainees alike. It was a vivid example that challenged existing paradigms and inspired a deeper examination of the factors contributing to survival against seemingly insurmountable odds. During weekly medical rounds, Mark's clinical course was analyzed meticulously. Neurologists presented serial assessments of his cognitive and motor function. Cardiologists reviewed echocardiographic findings and myocardial recovery, and intensivists detailed the critical care strategies employed to stabilize him. This collaborative review provided a comprehensive picture of his complex journey and highlighted the importance of interdisciplinary approaches in managing such cases. One of the most compelling discussions centered around the potential contributors to Mark's remarkable survival. Several hypotheses emerged. The high-quality, uninterrupted CPR delivered by the emergency team likely played a pivotal role, ensuring sustained perfusion to critical organs during the arrest. The timing and dosing of medications, including epinephrine, were scrutinized for their possible impact on resuscitation success. Additionally, Mark's individual physiological resilience, perhaps influenced by genetic or metabolic factors, was considered a crucial element in his ability to withstand prolonged hypoxia. The case also underscored the importance of early recognition and rapid initiation of resuscitation efforts. Although the exact downtime prior to hospital arrival was unclear, the paramedics' swift response and efficient handover to the emergency department set the stage for the intensive interventions that followed. This sequence of coordinated care from pre-hospital to in-hospital settings exemplified the systems-based approach critical to optimizing outcomes in cardiac arrest. Mark's survival challenged established protocols that often recommend cessation of resuscitation efforts after a defined period without return of spontaneous circulation. His case suggested that strict adherence to time limits might overlook the potential for late, unexpected recovery. This realization prompted spirited debates within clinical governance committees about the flexibility of guidelines and the need for individualized decision-making in resuscitation. The case also served as a catalyst for research initiatives aimed at better understanding the physiological thresholds of organ tolerance to ischemia and hypoxia. Investigators explored biomarkers that might predict recovery potential and studied the effects of prolonged resuscitation on neurological outcomes. Mark's experience became a reference point in these endeavors, illustrating the clinical relevance of such inquiries. Educational sessions incorporated Mark's case to reinforce the principles of high-quality CPR, the significance of teamwork during resuscitation, and the emotional complexities inherent in such situations. Trainees were encouraged to reflect on the delicate balance between evidence-based practice and the unpredictable nature of human physiology. The narrative of Mark's survival enriched their understanding of both the science and art of emergency medicine. In addition to clinical discussions, ethical considerations were a recurrent theme in these forums. The tension between prolonging life and ensuring quality of life after resuscitation provoked thoughtful debate. Mark's case highlighted the necessity for clear communication with patients' families about prognosis, potential outcomes, and the uncertainties involved. It underscored the value of shared decision-making and ethical frameworks in guiding care. Mark's journey also influenced policy discussions on resuscitation practices. Hospital leadership reviewed protocols to incorporate lessons learned, emphasizing flexibility and awareness of atypical presentations. Training programs were updated to reinforce the importance of perseverance balanced with clinical judgment. These changes aim to enhance patient-centered care and optimize resource utilization. The broader medical community took note as well. Conferences featured presentations on Mark's case, illustrating the evolving understanding of cardiac arrest management. His story was cited in journal articles examining survival after prolonged resuscitation, contributing to the growing body of literature advocating for nuanced approaches to resuscitation duration and techniques. Beyond the clinical and academic realms, Mark's case inspired introspection among healthcare providers about the emotional impact of resuscitation. The ordeal underscored the need for support systems addressing burnout, moral distress, and the psychological toll of managing critically ill patients. Institutions began to prioritize wellness initiatives and debriefing practices to foster resilience among staff. Reflecting on these broader implications, I recognized how Mark's survival transcended the individual and became a symbol of medical possibility. His case compelled us to question assumptions, embrace uncertainty, and strive for continual improvement in our practice. It reminded us that medicine is a dynamic field shaped by both scientific advances and the lived experiences of patients and providers. Mark's case also reinforced the importance of hope in clinical care. While grounded in evidence, Hope motivates perseverance and fuels the commitment to explore every avenue for patient recovery. His unexpected survival was a testament to this spirit, a beacon encouraging clinicians to remain vigilant, compassionate, and innovative. As discussions about Mark's case continued, they fostered a culture of inquiry and collaboration within our institution. The lessons learned prompted us to examine our protocols, training, and support systems with renewed rigor. Mark's story became integrated into the fabric of our medical community, shaping how we approach resuscitation and critical care. Ultimately, Mark Reynolds' survival challenged us to reconsider the boundaries of what is possible in emergency medicine. His case illuminated the complexity of human physiology and the profound impact of coordinated, compassionate care. It served as a powerful reminder that behind every clinical guideline lies the unpredictable reality of individual patients, and that sometimes, against all odds, life finds a way to persevere. The case of Mark Reynolds left a profound imprint on me, both professionally and personally. As an emergency physician, I am trained to approach each resuscitation with clinical rigor and emotional detachment, but Mark's journey challenged that balance. The experience reshaped my understanding of mortality, resilience, and the unpredictable nature of human survival in ways I had not anticipated. Throughout the resuscitation and subsequent recovery phases, I found myself grappling with a spectrum of emotions, from hope and determination to doubt and vulnerability. The initial flatline and prolonged silence of Mark's heart tested my confidence in established protocols. Yet, witnessing those faint signs of life emerge against all odds reignited a profound sense of purpose and belief in the limits of medicine. This case forced me to confront the inherent uncertainties that define emergency care. Despite advances in technology and knowledge, the boundary between life and death remains permeable and elusive. Mark's survival was a powerful reminder that medicine is not a precise science, but an evolving discipline that demands humility and openness to the unexpected. The emotional resonance of Mark's story extended beyond the clinical setting. It reminded me of the human stories behind every emergency, patients with families, histories, and hopes that transcend the immediate crisis. The weight of responsibility we carry as physicians is immense, and cases like Mark's underscore the need for empathy alongside expertise. Mark's journey also highlighted the importance of perseverance. In emergency medicine, it is easy to become desensitized to the frequent losses we encounter. Yet, his case reaffirmed that persistence, in the face of uncertainty and exhaustion, can yield remarkable outcomes. It taught me that hope is not naive, but a vital component of healing and recovery. The experience deepened my appreciation for teamwork and collaboration. The seamless coordination among paramedics, nurses, respiratory therapists, pharmacists, and physicians was instrumental in Mark's survival. Witnessing this collective effort reinforced my belief in the power of multidisciplinary care and the strength found in shared commitment. I also became acutely aware of the emotional toll such cases exact on healthcare providers. The intensity of prolonged resuscitations, coupled with the unpredictability of outcomes, can lead to burnout and moral distress. Mark's case reminded me of the importance of institutional support, open communication, and self-care to sustain resilience among medical teams. Reflecting on Mark's recovery journey, I was inspired by his resilience and determination. Despite the severity of his condition, he engaged actively in rehabilitation, embodying the human capacity to overcome adversity. His story became a beacon of hope, not only for his family, but for all of us who care for critically ill patients. The case also influenced how I approach conversations with families during critical moments. Mark's uncertain prognosis and gradual improvement underscored the need for honesty tempered with compassion. Navigating these delicate dialogues requires sensitivity to the emotional landscape of patients and loved ones, fostering trust and shared decision-making. Mark's survival challenged me to rethink the metrics by which we judge success in emergency medicine. It is not solely about immediate survival, but about the quality and meaning of life afterward. This perspective informs my ongoing commitment to holistic care that addresses physical, neurological, and psychosocial dimensions of recovery. As I shared Mark's story with colleagues and trainees, I emphasized the lessons of humility, hope, and perseverance. His case serves as a powerful teaching example of the complexities and uncertainties inherent in resuscitation. It encourages clinicians to balance evidence-based protocols with individualized judgment and to remain open to the extraordinary possibilities within medicine. The experience also reinforced my dedication to advancing resuscitation science and improving patient outcomes. Mark's case highlighted gaps in our understanding and the need for continued research into optimizing resuscitation techniques, neurological protection, and post-arrest care. It fueled my resolve to contribute to this evolving field. Ultimately, Mark's journey reshaped my professional identity. It reminded me that medicine is a deeply human endeavor, marked by triumphs and uncertainties alike. His story instilled in me a renewed commitment to approach each patient with scientific rigor, compassionate humility, and unwavering hope. In the quiet moments of reflection, I often return to that emergency room. The tension, the relentless efforts, the flicker of a heartbeat returning from silence. Mark's case remains a touchstone, a reminder of why I chose this profession and the profound impact we can have when we push beyond the known. His survival is not just a clinical success, but a narrative of resilience, collaboration, and the enduring human spirit. It challenges us to embrace the unknown, to persist in the face of adversity, and to honor the lives entrusted to our care with empathy and dedication. Mark's story continues to inspire me daily, shaping how I practice medicine and how I live. It is a testament to the unpredictable nature of life and the extraordinary capacity of the heart, both literal and metaphorical, to endure, heal, and triumph. Mark Reynolds' story stands as a powerful testament to the mysteries that pervade emergency medicine, the fragile, often elusive boundary between life and death. His journey from clinical death back to sustained life defied expectations and challenged the very principles that govern resuscitation protocols. It was a vivid reminder that, despite advances in science and technology, the human body's capacity for resilience remains incompletely understood and sometimes astonishing. For me, as an emergency physician, Mark's case cemented an enduring commitment to advancing the field of resuscitation. It underscored the importance of continually refining our techniques, protocols, and understanding to improve patient outcomes in the most critical moments. The lessons gleaned from his survival have informed training programs, inspired research initiatives, and shaped clinical guidelines within our institution and beyond. Yet, beyond the technical and scientific dimensions, Mark's story is fundamentally about hope. The hope that drives clinicians to persist in the face of overwhelming odds, the hope that sustains patients and families through the most harrowing experiences, and the hope that fuels the relentless pursuit of healing. His case embodies this hope and serves as a beacon for all who confront the life and death challenges inherent in emergency medicine. In the years since Mark's resuscitation, I have carried his story with me, sharing it with colleagues, trainees, and patients alike. It serves as a reminder that medicine is as much about embracing uncertainty as it is about applying established knowledge. Each patient is a unique narrative, capable of surprising us, challenging us, and teaching us anew. Mark's survival also deepened my appreciation for the collaborative nature of healthcare. The seamless teamwork among paramedics, nurses, respiratory therapists, pharmacists, intensivists, and specialists was crucial in transforming a dire prognosis into a story of recovery. Their dedication and expertise exemplify the collective effort required to push the boundaries of what is possible in saving lives. The emotional imprint of Mark's journey endures as well. It reinforced the importance of compassionate care, clear communication, and emotional support for patients and families navigating the aftermath of critical illness. It highlighted the need for healthcare providers to cultivate resilience and self-care, recognizing the profound impact such cases have on those who bear witness. Mark eventually passed away years later, his life a testament to both the triumphs and fragilities of human existence. His case remains a compelling example within cardiology and emergency medicine, emphasizing the heart's complexity and the necessity for ongoing research. The scientific questions his survival raised continue to inspire inquiry and innovation. Reflecting on this journey, I am reminded that every heartbeat carries a story, sometimes one of predictable course, other times a narrative that defies explanation. Mark's story challenges us to push beyond current knowledge, to question assumptions, and to remain vigilant in the face of the unknown. It calls us to honor the resilience of the human spirit and the profound responsibility entrusted to those who stand at the bedside. In honoring Mark's memory, I reaffirm my dedication to the relentless pursuit of knowledge, the compassionate care of patients, and the hope that guides every effort to bring life back from the edge. His story lives on as a beacon, inspiring all of us in emergency medicine to strive for excellence, to embrace uncertainty with courage, and to never cease seeking answers in the shadows of medicine's unknowns.